Welcome, curious minds, to the deep dive. Today, we're plunging into, well, one of the most persistent challenges in healthcare, isn't it? Getting cutting-edge research, the really good stuff, out of journals and, actually to the patients. It's like finding a cure and then just leaving it on a shelf. So our mission today is to unpack the origins, the backstory, and the real science behind a model designed to tackle this head-on, the Agile Network.
We're digging into pages 17 to 27 of the book, The Agile Network. It's by Dr. Malaz Boustani. He's a professor over at Indiana University, and his co-authors, Dr. Richard J. Holden, Dr. Jose Azar, and Dr. Craig A. Solid.
That's the plan. We really want to get under the hood here, understand why this Agile Network thing even came about, how it was built, and crucially, the science making it tick, things like network science. It's fascinating because it starts with a very personal story that kind of snowballs into this big idea for changing the whole system. All right, let's start there with that personal spark, because it really does set the scene. Dr. Boustani, here's a guy, a successful clinical investigator in brain health, publishing everywhere, getting grants.
Yeah, loads of funding, top journals.
But he was deeply frustrated. His work, especially on things like delirium, Alzheimer's, it just wasn't getting put into practice widely. He actually called it the research to bookshelf problem.
Exactly. And that frustration, it wasn't just professional, it hit home hard. The book tells the story of Tommy, who was Dr. Boustani's father-in-law.
Ah.
So imagine this. You're a top researcher studying the very things affecting your loved one delirium risk, the dangers of certain drugs like anticholinergics.
Which his research had flagged.
Right. His own work highlighted the risks, the links to Alzheimer's. And yet the system, even with a knowledgeable family involved in healthcare, it failed Tommy. He was exposed to those inappropriate meds. And the stats are just sobering. For 20 years, something like 1 in 4, maybe 1 in 5, older Americans getting these risky anticholinergic drugs. And that rate hasn't budged.
Unbelievable.
Even Dr. Boustani's family couldn't persuade Tommy against a risky surgery. Why? Because the advice came from a mobile ultrasound unit at his church. That messenger had more sway. It shows the problem isn't usually bad doctors or bad research.
It's the system itself, the connections, the trust, how information actually flows or doesn't.
Precisely. It's a system problem.
You can just feel the drive that must have come from that experience. This wasn't theoretical anymore. And that led him to create something tangible, right? The Healthy Aging Brain Center, the HABC.
Yes, and the speed was, frankly, incredible. He had a pivotal clinical trials published in May 2006. We're talking top journals like JAMA.
Right.
By January 2008, HABC was open, serving the public. That's, less than 24 months?
That's moving at light speed for healthcare implementation. Where was it based?
At Eskenazi Health in Indianapolis. It's an urban, county-supported system, so it served a really diverse population in Marion County, privileged and underprivileged alike.
So launching that fast.
Yeah.
What were the big hurdles? And what did they learn from doing it so quickly? Was it just about pushing hard?
Well, pushing hard, yes, but strategically. The main hurdle was, the usual suspects.
Yeah.
Bureaucracy, inertia. The lesson learned was the power of that agile approach, even before they fully named it that. Focus on the core, get it launched, learn, adapt, don't wait for perfection. And it worked. HABC became a flagship program by 2015.
And the models it used, they were proven effective.
Oh, yeah. Validated by those randomized trials, the ones in JAMA and another in the Annals of Internal Medicine in October 2006, they showed clear improvements in patient outcomes. And importantly, they reduced the burden on caregivers, the unpaid family members.
How do they do that, practically speaking?
They used trained care coordinators, people who acted as bridges between primary care, the specialists, community help. They offered personalized brain care plans and coached caregivers on problem solving for dementia-related issues.
Okay, so the HABC success story was crucial. And Dr. Boustani's big takeaway from that was seeing the power of complexity science, network science, behavioral economics.
Yeah.
How did running a clinic connect to those big ideas? What was the aha moment?
I think the aha was seeing how HABC worked. It wasn't just the treatments, it was the connections. Connecting people, connecting information differently, adapting quickly to what patients actually needed, focusing on behavior.
It wasn't just a flowchart.
Exactly. It was dynamic. He realized the translation problem, getting research into practice, wasn't just about knowledge gaps. It was baked into the structure of healthcare. These sciences, complexity, network science, they gave him the tools to actually see that structure, understand it, and crucially, figure out how to change it.
And that became his focus. Agile innovation, agile implementation.
That became the mantra, yes. Constant learning, adapting, improving based on real-world results.
So HABC is this bright spot, this proof of concept working.
Mm.
But like you said, it's one clinic. How do you scale that impact, especially when the whole funding landscape was shifting dramatically?
Right. You had the Great Recession looming large then. That really hit research funding hard. Federal money, private money, it all tightened up.
Yeah, you mentioned the NIH funding rates dropping significantly.
Dramatically. Going from funding maybe the top 20% of applications down to only the top 10%. Getting resources for new, ambitious projects became incredibly tough.
But sometimes constraints breed innovation, right?
Exactly. And paradoxically, opportunities arose from the policy changes after the recession, specifically the Affordable Care Act.
Oh, okay. How so?
The ACA set up two key bodies, the Center for Medicare and Medicaid Innovation, CMMI, and the Patient-Centered Outcomes Research Institute, PCORI.
Right, I've heard of those.
And their whole purpose was to fund and test new ways of delivering care models that improved quality, boosted population health, and ideally lowered costs. It was a signal from the top. We need to innovate how care actually happens.
And the leaders at Indiana University School of Medicine saw this opening.
They did. Dr. Anantha Shekhar and Dr. David Wilkes, they saw these new funding streams and Dr. Boustani's work with HABC, and they put two and two together.
So they tasked Dr. Boustani with something new.
Yes, they asked him to establish a new center, the Indiana University Center for Health Innovation and Implementation Science, CHIIS for short.
CHIIS, okay, and its mission.
A big one. To transform existing healthcare organizations into these agile networks.
Using that iterative process you mentioned.
Exactly. Deeply understand the problem first. Generate solutions you can actually test. Check your assumptions constantly. Tailor the implementation locally. And learn fast from failures just as much as successes. Always focusing on the minimum specifications to get started and scale.
Okay, so CHIIS says is established, the mission is clear. And then comes this almost movie-like moment, a think-a-thon.
Ha! Yeah, pretty much. In 2014, CHIIS holds this healthcare think-a-thon at Turkey Run State Park in Indiana. Almost 100 people, all focused on healthcare transformation.
Sounds intense.
It was. And during a break, Dr. Boustani takes this long 2-hour walk with Randy Hounts.
Randy Hounts, an engineer.
An engineer with an MBA from Purdue, yeah.
Huh.
And Randy had a ton of experience in technical assistance, helping practices transform, especially in rural areas.
So different backgrounds, but what made them click instantly?
Shared passion, I think. A passion for practical change, for making things actually work better on the ground. Randy's engineering mindset, that process focus, really meshed with Dr. Boustani's clinical insight and his growing interest in complexity in networks. They both saw healthcare's problems could be tackled using ideas from other fields.
And then the timing.
Oh, the timing was unbelievable. Just 7 days after that walk.
No way.
CMS drops this request for proposals. They want to set up networks for something called the Transforming Clinical Practice Initiative, or TCPI.
Wow.
And get this, Randy and Dr. Boustani apparently tried calling each other at the exact same time to talk about it. Both went straight to voicemail.
That's incredible. Serendipity defined.
It really felt like the pieces were just falling into place. Their idea suddenly had a potential home, a major federal initiative.
And they needed one more key player.
Right. They brought in Dr. Abel Coe. He was a mutual colleague, a physician scientist really passionate about using health IT technology to drive healthcare transformation.
So you got the clinical expertise, the implementation science, the engineering process view, and the tech piece. A powerful core team.
Definitely.
So, okay, they have the team, they have this massive opportunity from CMS. And what's really cool is how they approached the application itself. They didn't just write about being agile.
They were agile. They used their own agile innovation process to build the proposal for the Great Lakes Practice Transformation Network, or GLPTN.
How did that work in practice? For writing a grant proposal.
Think fast prototyping. They banged out the first draft, the first prototype of the application in under 30 days.
Wow.
Then, instead of just polishing it internally, they spent the next 8 weeks in rapid feedback loops. They shared it with their growing network, potential partners. Colleagues got input, revised, improved, got more input.
So they were building the network while building the application for the next.
Exactly. They were living the methodology, iterating constantly based on real feedback.
And did it work? Did they get the funding?
They did. About 8 months after starting that whole intense process, GLPTN was chosen, one of only 28 awards nationally under the TCPI.
Fantastic. And the GLPTN's mission?
To create these agile networks across 4 states, Illinois, Indiana, Michigan, and Kentucky, Networks capable of that iterative problem solving needed to hit the triple aim.
Your triple aim. Remind us.
Better health for the population, excellent quality of care but at a lower cost, and importantly, great experiences for both patients and the providers doing the work.
Hey, this is huge. A multi-state network built on Agile principles.
Yeah.
Now, let's get into the science underpinning it.
Mm.
You mentioned network science earlier. This wasn't typically applied to healthcare systems like this before, was it?
Not on the scale, not with this explicit focus, and it's transformative because it changes how you even see a hospital or a clinic.
How so?
The fundamental idea is all healthcare delivery organizations are networks of individuals. It sounds simple, but it shifts the focus from individual parts, a doctor here, a lab there, to the connections between them.
The web, not just the spiders.
Exactly. And that leads to the idea that the whole is greater than the sum of its parts. How these individuals collaborate, share information, support each other. That collective action delivers a level of care no single person could manage alone. Think back to Tommy's journey again.
Right.
His care wasn't just a list of appointments. It was his movement through this huge, complex, interconnected network. The diagnostic unit, the surgeons, the nurses, the rehab, the long-term care, even the family caregivers. It's all linked.
And the quality of his care depended on how well those links worked.
Precisely. The connections are critical. In network science terms, you have nodes. Those are the people, the individuals.
Doctors, patients, nurses.
Right. And then you have links. That's how they interact. Sharing information, sending referrals, maybe just providing support or energy.
Okay.
And here's where it gets really interesting. As networks grow, they tend to develop what are called fractal structures.
Fractal, like those repeating patterns in nature.
Exactly like that. Think of a tree branch looking like a tiny version of the whole tree, or blood vessels branching. Networks develop similar self-repeating patterns at different scales.
Why? What's the advantage?
It's incredibly efficient for distributing energy and information, which is vital for the network's survival and function. In healthcare, it means information or a care process can flow efficiently through the system, even if one part is blocked or overloaded. The structure itself builds in resilience.
So the connections, the links between the nodes, they determine how quickly things spread. Information, best practices.
Absolutely. It's just like airline routes, right? You might not have a direct flight everywhere, but the network of connecting flights lets you get between any two airports relatively quickly. Good network structure means faster spread of innovation, better coordination.
Wow, okay. So we've gone from a personal frustration, this research, to bookshelf problem.
Yeah, starting with Dr. Boustani and Tommy's story.
Through navigating this really tough funding environment after the recession, seizing new opportunities from the ACA,
Leading to CHIIS and that fateful walk in the park.
to building this huge four-state Great Lakes practice transformation network, the GLPTN, using Agile methods.
All underpinned by these powerful ideas from network science, complexity, behavioral economics. It's quite a journey.
It really is. It shows how understanding these deep dynamics, these connections, can help tackle massive healthcare challenges.
It's about seeing the system differently, right? Not just individual components, but the whole interconnected web.
Yeah.
And then using principles like iterative problem solving, focusing on those nodes and links to actually make improvements.
So wrapping this up, what's the key takeaway for someone listening? How can understanding these network ideas maybe help us navigate things?
Well, think about it. These principles apply everywhere, not just healthcare. Your workplace is a network. Your community is a network. Even your family and friends form a network.
Okay.
So understanding who the key nodes are, how links form, how information or influence actually flows, that can be really powerful. Maybe you can identify bottlenecks or find better ways to connect people or ideas.
So it's about seeing the hidden structures.
Yeah, and realizing you can potentially influence them. This whole story shows that even really big, complicated problems, things that feel totally overwhelming, can be chipped away at. By thinking iteratively, by understanding the connections, by being a bit agile yourself, you can start building pathways to something better.
A powerful thought. Identifying those connections, understanding the flow, it gives you a different lens to look at almost any system you're part of.
Exactly. It's about seeing the network,